And I do encourage everyone that partakes in online discourse or, let's say, influence their opinions on things to exercise that with caution, because every single thing that is a trending issue, a trending discussion, it's influenced politically. There's something going on that makes that the topic of discussion at this moment in time. So just asking, why might this be happening? What could be the bigger picture here? What could be the intention behind this?
You're listening to The Pelvic Freak Show
with your hosts, Amanda Neary and Hannah Meyer. Hey, Pelvic Freaks. Welcome back to another episode of The Pelvic Freak Show.
Where you're freaks for us and we're freaks for your pelvis, baby.
That was good. You just got really passionate, so you needed a couple takes.
Yeah, and why am I passionate?
Because we are entering the chat about the internal war between pelvic floor PTs online, discussing the necessity of an internal assessment.
Yeah. Wait, let's do it together. We got to sigh. Ready? That's how we planned it. Ready? Okay, now we can go.
Now we can enter the chat.
Now we can enter the chat.
Why are we even entertaining this, though?
For a second, when I saw it, I was like, we shouldn't talk about this, right? Because but then no, we should.
No, I agree that we should.
Yeah.
But the reason we're entertaining this, and we're not just passing it off as something you scroll past, like, oh, there's a million opinions online, like, why even entertain something that's being silly? It's because, of course, this is happening at a time when there's a rise of conservatism in the country, of patriarchal thinking, of direct defunding of women's health research happening from our government. And of course, it's happening at that time that someone out there is pitting an area of healthcare that is founded by women, driven by women, utilized by women against itself to become this controversial area of practice. It's trying to devalue pelvic floor therapy is what's happening.
Yeah, if we really zoom in on it, because I feel like we'll have a unique perspective on this, because I feel like we kind of escalate things, and we're super real on our opinions.
Well, we always look at what is the big picture here? I'm not a details person. The details are important, but they're not as important as why would this be happening at this moment in time?
Yeah.
What is this actually trying to do? What's the big picture behind this? And there can be no positive big picture to talking shit about one area of practice versus another.
Yeah. And if you guys don't know what we're talking about, I'm sure that many of you do. If you are online, if you are a pelvic health therapist, if you're a pelvic health OT, if you're a pelvic health PT, maybe if you are a patient and you're following a lot of pelvic floor practitioners, or even if you're another specialist, like a sex therapist or whatever it is, a dietitian, and you are seeing this discourse among PTs online. So pretty much what is happening is that, okay, so Nicole Cozine, she's a big leader in the pelvic health field, right? And I think what happened was she kind of came out and made a statement listen, internal exam. I don't know if she was the start of it. I feel like she was the one who kind of really started the conversation online, which I respect, but pretty much said okay, internal exams are necessary for our field. And if you call yourself a pelvic floor therapist and you're not doing internal exams, this is gold standard for our practice. And it's hard for you to call yourself a pelvic floor specialist if you're not doing internal treatments on people. Kind of calling out people for I don't know. I feel you guys to listen to our episode on pelvic sanity and kind of get kind of the rundown of where this started, but pretty much just calling out people for not doing internal exams. Okay. Which I agree with her. I think internal exams are necessary.
Would you call yourself a specialist in any area of PT without being able to assess that area of the body?
Dude, no.
No, you wouldn't. It's just, to me, that part of the argument is so ridiculous that people are even having that conversation.
Yeah, exactly.
It's wild.
If you call yourself a spine specialist and you're not doing a very intensive exam of, the thoracic spine, the cervical spine, the lumbar spine, and assessing in even more detail than a typical ortho PT, how can you call yourself a spine specialist, or a knee specialist, or a specialist on the fitness athlete. Like, for example, like you're going to have more intensive knowledge than the other providers in your realm.
Yeah, correct.
Exactly. So I kind of want to deep dive into some of the part of the podcast that we heard. Like, one of the things she said was, you know, maybe there's some practitioners that maybe have trauma centered around this, where they're like, I don't want to do an internal exam because of like a previous experience of trauma I've had. I don't feel comfortable with that. Or maybe there's religious reasons why I won't do internal treatment for someone. Do you have anything to say on this portion?
Yes, I think that's real. And I think that's just not the area of PT for them, unfortunately.
Yeah.
Like, and I think her point on the podcast was that there's practitioners who really enjoy treating women's health in these conditions. You can be a pelvic floor informed clinician,
yes,
without being a pelvic floor therapist.
Yes.
So if the internal exam is really something you're unwilling to do, I would say don't go into the field of pelvic floor therapy specifically. You can have a few in your pocket. You can learn from them. You can inform your care through them. But there's a difference between calling yourself a specialist and focusing on that.
Exactly. Like, I couldn't have said it better, and I knew you were going to say it so well. You can call yourself an ortho PT with more knowledge in the pelvic floor space.
Yeah.
You can say that you're like a pelvic floor informed ortho PT. Like, you're going to screen for pelvic floor. You're going to ask about urinary history. You're going to ask about bowel. You're going to ask about, you know, maybe whatever it is. You're going to do those screening questions, which every PT should be doing, by the way, if they think that the pelvic floor could be evolved, which I feel like most of the time it usually is. But anyways, it's a difference between then also being like, okay, yeah, I'm a pelvic floor specialist, and someone is coming to you for that care thinking they're going to get gold standard pelvic floor care, and then you're not even treating their pelvic floor. That's where it becomes to a problem. I kind of like compared that when this topic was brought up. I'm like, but okay, if you're an OB-GYN, if you're a gynecologist, and then you're going to say that like that makes you uncomfortable, like, you're not going to be able to treat your patients, honey. No. Like, I'm sorry, but you can still be a PT with that likes to, you know, involve the pelvic floor in some of their treatment, but you're going to have to know when to refer out, because an internal exam may be necessary at some point.
Totally.
But I don't know. I feel like that's my take on that.
Yeah, no, I agree.
And then there's the other aspect of like people kind of like literally just trying to make a quick buck off people.
Yeah.
Trying to like sell PT, being like, okay, like, in-person pelvic floor PT and the internal exam isn't going to help you. So like, take my workshop, take my class, whatever it is.
Yeah.
What do you think about that?
I am livid about that aspect of it, because there is a very healthy and real way to offer online pelvic floor therapy. And I think the counter argument there is, well, if you're not okay with it, if with virtual being the assessment, then you're limiting access, because not everyone has access to a in-person pelvic floor therapist. Okay, you can be a pelvic floor therapist who agrees the internal assessment is the best way to physically assess the pelvic floor muscles, who also recognizes that maybe not everyone has access to that where they are, so they are equipped to do it online and give patients that option if they're in a different area. But if you are saying, actually, the physical assessment is completely unnecessary for pelvic floor therapy, all you need is this 3-week program, and you're actually going to be better. And I know what's going on because this is sometimes what goes on. That's a different thing. And that's capitalistic, and you're focusing on it from a sales perspective. And I don't like it.
Yeah, dude. No, I really don't like it either. And I also want to say, okay, I want to take another note, because we actually we're taking the ICE physio course for like the fitness athlete one, which great course, but that's not what we're talking about today. But I want to talk about something they mentioned in one of the lectures that really went home with me. And I think this is a comment, like, people who aren't willing to do the internal exam because of their like internal biases, they're uncomfortable with it. We cannot let our own discomfort and our own biases determine how we treat our patients. We cannot let that impact our patient care. Mm-hmm. You know, like, we cannot put that out onto our patients. That's going to severely limit their experience with PT. So that's with anything. That's not even with like pelvic floor. That's like with, if you're treating a low back and you think like, oh, like I'm afraid, if you have low back pain, a history of low back pain, and you're afraid to move, you can't let that impact your patients. We all know that, you know, the best care for like low back pain is strength training. Like most of the time it's because of a weak back. Like we need to strength train and get you feeling comfortable and confident in moving and limit that fear avoidance. But if you yourself are scared to move your spine when you are in pain, or scared to move when you're in pain, like you don't want to put that out onto your patients.
Totally.
So I feel like that's an important note that I feel like I wanted to make, but I didn't.
That's actually a really good point, because even in pelvic floor courses, I have heard the example a lot, like, oh, would you want this to happen to you? Like, I wouldn't want to be doing this for too long. Like, if you're spending so much time internal, like there's so much, well, I wouldn't like this. Well, I wouldn't like this. And it's like, okay, if you're a seasoned clinician, you know how to obtain informed consent, continual consent from your patient, how to read their facial expressions, their body language, to know what they're comfortable with, what they're prepared for.
Yes.
It's not about what you would prefer. That's a good point. And I also feel like, because we're talking about an intimate area, it's so much easier for people to write off and say, well, I wouldn't like that. So like, I'm just going to find the reason that we don't need to do that.
Yes, exactly. Which kind of leads me in to the other point that was made, which is that, you know, why should we be doing this? There's some patients that aren't comfortable with the internal exam, you know, and we're always actively, like Amanda said, making sure that this is consensual. Like this patient is giving written consent. This patient is giving verbal consent. And then on top of that, we're checking in with the patient the entire time during the exam. We're reading into not only verbal consent, but also body language, which we've talked about tons of times, which we're like, okay, visibly you are uncomfortable. We're going to end this assessment because there's no point in this right now. If you are physically uncomfortable right now, maybe we can try again another time if you would like. Or, okay, sometimes people do deny the internal exam. That doesn't mean that we shouldn't be doing internal treatments, internal assessments.
Actually, yeah, I forget who co-hosts the Pelvic PT Rising podcast with Nicole Cozine.
I think it's her husband.
That's her husband?
I am pretty sure.
Dang, I didn't even know that.
Which is Slice.
He's not a pelvic floor therapist, but he made a really good point in the episode. He said just because it isn't right for every single patient doesn't mean it's not the gold standard.
Yes. Jesse Cozine.
Hear that again.
No, say it again.
Just because it's not right for every patient doesn't mean it's not the gold standard.
Yes.
That is so true across all areas of medicine and rehab. Every single intervention isn't going to be for every single person, but we still have the best ways to assess tissue, to assess disease, to find diagnoses. And that doesn't change because it doesn't work for one person.
But for some reason, when it's associated with the vagina and internal muscles, it becomes a much bigger deal.
Yeah. Because why? It's another way to police women's bodies.
It really does, like, it really does go back to that if you really like lean into it.
100%. Because also, what are you doing by saying we need less in-person PTs that treat this across the country and we just need online programs? You're limiting access. You're now telling people it's not worth it for you to go get certified in how to assess a pelvic floor because they can take this course that comes out of California and they never have to experience this in another state that doesn't have it. Now you are the reason people are limiting access to care.
Yeah, dude. And then this is the other thing that Jesse and Nicole went into, or Dr. Cozine went into on the podcast, which they said there's a difference between access to care and access to quality care. Like they said this important note where they were like, yeah, everyone has access to care if you really think about it. If they have like, you know, they can throw $10 at this workshop or whatever and they can get some type of care, but is it going to be quality gold standard care that they're receiving? No. And that's going to get really confusing to like the average consumer, the average person, like scrolling online, Google searching, looking up on TikTok, like, why does my pelvic floor feel this way? Why does this happen? Why does this happen?
Literally. It's already an area of healthcare that people know so little about, and they're going to experts on social media to get an idea of who to trust and what resources to access. And now those professionals on social media are all butting heads. So it's a who do I believe situation in such a small field of practice.
Yeah. And there's different ways to treat the pelvic floor. And then we're not also shitting on telehealth. Like,
No.
we have to put that out there too.
We love telehealth. We offer it.
Yeah, we even had a discussion with a vagina rehab doctor. We did an episode with her. It was a great episode on who could benefit from, listen to that, who could benefit from online pelvic floor rehab, because not everyone can benefit from it. Maybe you could even have it in your plan of care. It doesn't have to be solely all telehealth, but there are specific groups of people that, could benefit from telehealth PT.
Also, in the realm of like making a quick buck, most people that are doing that are selling a course or program. So they're not actually one-on-one in a telehealth session. What we did talk about with the vagina rehab doctor is that those sessions, the physical therapist is guiding you through a physical assessment. Those tissues are still being assessed under supervision of a professional, and that's how we would treat our patients on telehealth as well. And then any like exercise program, something like that, would be supplemental to care. That's not the first plan of care. So there are different ways to even practice telehealth.
Yeah, no, there are various. And another thing I want to say on that, sometimes I'll even recommend telehealth PT for people, maybe for like what we were saying earlier, patients that come in and they're like, actually, I'm not doing that internal assessment, girl. Like, not for me. Peace out. Okay, like, don't leave. Let me tell you this first. Maybe you would benefit from telehealth. Like, I can still help you and maybe guide you via online. You're at home, like you're in a safe space. It's just you, camera off, like, and I'm assisting you on doing an assessment. If anything, I still think the internal assessment is that important to where like, I want you to assess your pelvic floor, and there are times that we're like, patients aren't even comfortable with that. And then we work around it to the best that we can. And there's sometimes patients, like, sadly, like we plateau, and I know deep down, I'm like, oh, if I could just like see what your pelvic floor is doing, I know we could get that like extra push to like really, really help you. Like, I know it, but like sometimes, it's the patient choice at the end of the day and like their comfortability. And that's that, you have to honor that, of course, but that just kind of shows like how much I know the internal assessment is needed. Should we talk a little bit about kind of like why the internal, like why we think it's important?
Yes. And I was actually going to say this because we understand symptoms. We understand what things could be. Have the results of an internal exam lined up for you with a patient's description 100% of the time, where you could just assume that the pelvic floor is going to feel a certain way and it's 100% of the time correct? No. That's not how it works. Like, you wouldn't just hear, if you're in person with someone and you have the opportunity to assess their knee and they're telling you all these symptoms, you're not just going to say, oh, well, it's this because of what you said, it's probably this. And I'm not even going to look at the joint. It's the same thing with the pelvic floor. Like, I can assume there's probably tension there with certain symptoms that you're describing. We might have some weakness. I'm not going to assume the grade of your perf testing or things like that we're really only going to get from that internal assessment. And it is still the best way to assess those muscles in isolation. It's the deepest area of the body we can physically assess in such an involved area. You have all of your hip planes of motion that are stemming from that pelvic floor. I feel like I became a much better clinician once I started assessing the pelvic floor at understanding the hips and low back and their involvement as well. And there's a million reasons why I think it's necessary.
Oh my God, dude. Like, so real, because that was another thing mentioned on the podcast pelvic sanity podcast, that so many people are saying like, I already know what I'm going to see. I don't need to do it, because there are so many trends, and like, we see a lot of hypertonic pelvic floors, or just increased tone or tension in the pelvic floor, I should say, or increased muscle restrictions, things like that, where you can like be like, okay, like I know what's going to happen, but big, but like, you don't always know. It can be like, I always catch myself too, where like a patient comes in, they're telling me this presentation. I'm like, yeah, I know exactly what this is going to be. Like, I've seen this before. Like, this is, I know I can help you. And I always have to like check myself and be like, calm down, Hannah. Don't do anything until you check the pelvic floor, because I don't want to get ahead of myself, but there's so much more than you can find from an internal exam rather than just even the perf assessment, right? Like if you just find yourself going and doing an internal assessment and you're like, okay, I'm just going to go through like what Herman and Wallace taught me. I'm going to do the strength test. I'm going to have them bear down. I'm going to do the external assessment. I'm going to have them, Kegel. I'm going to have them see how long they can hold it, do repetitions of that. I'm going to just like see if it feels tight or not. Like you're missing a big part of the internal assessment for sure, because like the breathing coordination that you can find from the pelvic floor, huge. Mm-hmm. How the tone of the pelvic floor, like how restricted they feel, huge. And going way past the perf assessment alone, which is the like guideline, like strength assessment that we all follow as we enter the field of pelvic floor therapy. Like I feel like there's just so many times when I know it's going to be beneficial. I think another argument out there is, oh, like people are doing internal assessments when it's like not necessary. No, that's not a thing.
No. And I'm not even familiar with like what clinics they're referencing in that argument, like, because obviously we work at a specialized pelvic floor clinic. Anyone that comes to us is coming for a pelvic floor assessment. It's necessary, I would say 100% of the time for the patients that walk through our door. Mm-hmm. But even if you're in an ortho environment, if something's indicating pelvic floor and you have a pelvic floor therapist on site and the patient consents to it and you talk about the assessment and what it entails, how is that unnecessary?
No, for real.
I don't know.
And also too, I feel like I have the skills to lead an internal assessment. Maybe you've been to other PTs. You've been to, let's say you're having hip pain or like lower abdomen pain or something like that. And you've gotten CT scans, you've gotten ultrasounds, inconclusive. You've been to PTs and like done clamshells off the wall for 1,000 years. You've done like whatever it is. You're doing bridges, you're doing clamshells, nothing's getting better. And then you come to me and I have this extra skill set. I'm like, has anyone checked your pelvic floor over the 5 years you've been in pain? We're missing a huge component of something that could be impact. I'm not saying maybe it's not the answer, but I'm saying, could we screen it and see? Mm-hmm. I tell people that all the time. If it's like such a weird thing where they're like, I don't know what this is, like, could my pelvic floor be involved? I'm like, let's screen it. Let's say we don't find anything from it. Let's say that like the pelvic floor feels fine. At least we screened it. And at least we did an assessment, right? Like, there's no harm in that, because then there's people that on the other end of the spectrum that go years that never seen what their pelvic floor is doing. And then that was the answer. And I'm trying to save you from being that person.
And we see that all the time.
Yes. And even so, let's say maybe you're having like, at the end of the day, the internal assessment, even if it isn't necessarily like, oh, they have a tight pelvic floor or something like that. Maybe you can learn so much about the breath. And the breath holding when you're telling someone to bear down or you're telling someone to Kegel and they're not, and like whatever their breath is doing, maybe they're like putting so much pressure on their abdomen or they're not engaging their core correctly. Like you can really see that from a pelvic floor assessment.
Yeah. I think the internal feedback with exercise breath coordination is one of the biggest benefits to manual therapy that we have as pelvic floor therapists.
Yes. And we don't do biofeedback at our clinic. We do internal exam because I want to use my finger. I want to feel what those muscles are doing. I'm not going to like use some like probe on like, I don't know, a quad. You know what I mean? I'm like using my hands when I'm like assessing a quad. I'm using my hand when I'm assessing the pelvic floor. Right. And I can give patients so many answers when they feel like they've been so lost just from what I can gather from an internal assessment.
Also, it's important to put your hands on the patient because the patient can sense what's happening to them. Their part of your assessment is their pain response and their symptoms present with an assessment. But if you're using a probe or a wand, you don't have the tactile feedback yourself to assess muscle tone and what their baseline is for that muscle. That's why we would never assess a quad with a biofeedback wand.
Okay, yeah. So everything we've talked about so far, I feel like you can hear from like other people online having the same discussion. And I think another important thing that was mentioned in the podcast episode that me and Amanda both listened to that we've been referencing from Pelvic Sanity is one last thing before we like kind of get into our like ending conclusions of our pelvic freakery. is that they reached out to the APTA and talk about this, how like the internal treatment is the gold standard of care. And like, I think they came at them with like other things that they're bringing up as like necessities in our field. And the APTA was pretty much like, yeah, we have a task force working on that or something. Like, don't worry, we'll get to it. Which is why they were like, okay, we need to talk about this. Which is why we literally have this podcast too. Like, we need to be the advocates for our field and for our patients. Like, we're just like, we want to advocate for better care. That's what we're doing.
Yeah.
We need to be the voice here because, you know, if we're just waiting for other people to do it, whether it's APTA, whether it's the government, whether it's whatever it is, we're going to be sitting on our asses for a long time.
Yeah. And at my last business conference, I met the president of the APTA. He was our guest speaker. His name's Kyle Covington. He's a nice guy. He's willing to hear what we want them to work on.
Yes.
You know, and I think a lot of people put government or governing bodies on pedestals where they're unreachable, right? It's like they work for you. So you need to be the advocate for that. Like, we want this to be talked about in public health. We need to hound it. We need to be the ones talking about it. Grassroots is everything. It's like where movements actually start and get productive. So we need to email them collectively, all of us together in agreement. Like, listen, public health needs to be prioritized more, and we need more research on this and data and statistics and gold standards written so people can actually reference this shit.
Yeah, and our field is so new, like still compared to so many other fields of PT.
Yeah.
So we're constantly growing and establishing ourselves as providers. And I know how important we are and how important we can continue to be. And if we're not going to have a voice and not like stand up for our career and point out these things that we're seeing as flaws, then, you know, then what? Like, we're just going to like let everything continue to be the same.
Yeah.
So the internal exam is necessary. The internal assessment, if you will, is necessary. According to Amanda and Hannah, your favorite pelvic freaks.
Yes.
All right.
Yes, absolutely. And I think this is another, you know, it's a war on women's bodies, of course, because we're in such a niche field, as I mentioned at the beginning, you know, started by women, heavily practiced by women, attended by women. PTs do this in general too. Like, I remember during COVID, the rise of the online PT influencer was happening, and there were the people that felt so strongly that stretching is detrimental and you should never have your patient stretch and like blah, 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 blah. And manual therapy is the devil. And
oh my God, yes.
Anyone who says they do manual therapy is a bad therapist and they shouldn't be allowed to post on social media. And it's natural with the tension social media creates for there to be a war in how you're treating patients versus someone else. We avoid that like the plague. We're not here to like shit on anyone else and how they treat patients. And I think on our like Vagina Whisperer episode, she had talked about that too, how she's like more so facilitating connection and not trying to like go at war with PTs online. And I find that really admirable because I think that's easy. It's easy to take the low road. It's easy to project your insecurities onto another clinician. And that's what I'm seeing a lot in this argument is like, well, I'm uncomfortable doing internal exams because you probably aren't comfortable doing them. You're probably not great at doing them yet if you genuinely think that they're not beneficial. And maybe that's a skill issue and something that you need to work on with your patients and your practice and getting more mentorship. And there's other ways around that. But the internal exam itself is an essential part of pelvic floor physical therapy.
Exactly. I like what you said about projecting your insecurities. Like, if you think that the internal assessment is not beneficial, then you may not be doing it exactly how you need to be doing it.
Yeah.
For real. Or you need some more continuing ed to learn. I would say, like, that's what I would say. If you see so many other practitioners saying like this is necessary, right? I would look into why other people are saying that it's necessary. Let me analyze how I'm doing the internal assessment if I don't feel like it's beneficial for people. You know what I mean? Like, if I truly do not think that, looking into it or asking those practitioners, like, you know, what are you finding that I'm not finding, or that I think I can just do based on just like, you know, just typical like PT, like pelvic alignment, whatever it is that you are doing if you're not involving the pelvic floor. You know what I mean?
Yeah. And I will say the only people I've actually met in real life that feel this way have been younger clinicians. A couple that I've interviewed to work at TPI before. And I remember them asking, like, do you do internal with most of your patients? And I said, yes. But I was almost like, as opposed to what?
You're like, yes, let me just see what they're going to say.
Yeah, I was kind of like, let's see what you say. And then one of them, I remember distinctly had said, oh, well, like, my last mentor, like, didn't really believe in internal, and like, I'm more exercise based. And I was like, okay, like, we're also exercise based, but that doesn't equal not believing in internal treatment.
Yeah.
Like, they need to both exist. If you're a pelvic floor therapist,
That does suck if it's like,
needless to say, that person does not work at TPI.
dude, and that's the problem with like mentorship in pelvic health too. Let's like take it all the way back to that. Because it's so hard to just take a course and be like, all right, I got this. And then you go into your first job as a pelvic health clinician, and then it literally depends on who you get as a clinical instructor for your student and who you get as your mentor at your first job. At my first job, my mentorship was way different than how we do it at TPI, because we know and we're constantly evolving our mentorship program too, to make sure our clinicians are confident in their skills, right? And how they're making sure everyone is treating in terms of the Pelvic Institute's values and our gold standards of how we know patients will get better, right? And then from there, you can have flexibility within your treatment, right? But like, there are things that are required. Like at the Pelvic Institute, you have to be able to do an internal assessment. It's going to be one of the main things that we provide our patients, whether you're a patient with a penis, whether you're a patient with a vagina. We do internal rectal, we do internal vaginal.
Yep.
That's
our gold standard.
And during pregnancy, we do internal treatment. And I think that is also so necessary, that I learned in my first job. Yep, we don't do internal for our pregnant patients because that's a risk. What?
I'm sorry, does your pregnant patient, are they allowed to have sex?
I'm sorry, excuse me. Like, what is this finger doing that is risking this pregnancy? Like, I'm so confused.
Yeah.
But exactly. So that's a conversation for another day. But I feel like we hit a lot of the main points of what we wanted to tap in this conversation with.
We entered the chat effectively.
We did. I think we did enter the chat. Let us know if you guys hate what we said. Let us know if you love what we said. Let us know if you feel like we need to go into more detail on things that we said.
Yeah.
But I think the one of the important notes that came up within this is honestly what Amanda brought up, with like this being a bigger issue than just like clinicians arguing with each other. Like, it's literally just, it's the fact that this is a women's health space. Like, we always talk, it's pelvic health. We treat all genders, right? But like, women's health specifically is a big part of our patient population.
Yeah.
Of course, this is the field where, you know, we're like targeting each other, right?
And I do encourage everyone that partakes in online discourse, or let's say influence their opinions on things, to exercise that with caution, because every single thing that is a trending issue, a trending discussion, it's influenced politically. There's something going on that makes that the topic of discussion at this moment in time. So just asking, why might this be happening? What could be the bigger picture here? What could be the intention behind this? I think gives you a lot of context on these situations. And it's not to say that there's bad arguments always, but I mean, having that context, I think, makes you a better researcher if you are someone who likes doing your own research too.
Yeah. And if you're a patient listening to this, this is a great episode for you to listen to know that we know why we value internal treatment, to know why we value internal assessments, to know why, like, if you are looking for a clinician, right, and you're looking for a pelvic health specialist, to know that it's important to value looking for someone that does prioritize internal treatment, or at least the assessment at bare minimum, right? So I hope that you guys heard us well today.
We hope you heard us well today.
Amanda has the babe light, so I'm going to shut the fuck up so she can talk.
Pelvic freaks, I have the babe light. Please leave us 5 stars if you've been loving the pod on whatever platform you're listening on, and leave a written review if it gives you that option. If it doesn't, leave us 5 stars and maybe a little comment that we will happily reply to. If you would like to DM us any questions, feedback, concerns, whatever, make sure you're following us on social media at The Pelvic Freak Show. And we love you.
Yes, and I have the babe light now. If you are a pelvic floor therapist, you have questions, you have comments, you have concerns about anything we said, why don't you shoot it in our chat box on Instagram?
Shoot it in our what?
Shoot it in our chat box. DMs, if you will. Let's put up like a question box. Maybe people can like write in questions. Maybe we can do a follow-up episode on this discussion, kind of like answering your questions or concerns. This is an open discussion for all right? These are our opinions, and we are open to your opinions and analyzing those as well. All right?
All right.
Thank you, pelvic freaks.
Bye, pelvic freaks.
Bye, pelvic freaks.